It's a pleasure and an honor to be with my NAMA friends whom I made over the years with so many meetings and conferences and travel till many of them became like family. So it's indeed very nice to be with you. On the other hand, it's really unfortunate that I am not there in person. There is an important family occasion that is happening over this weekend, and that's what's preventing me from travel. So hopefully we'll be seeing you in some other convention soon. With that said, I will proceed to my presentation. I was asked to talk about the COVID testing in general. And on purpose, what I did is I actually put a title that is fluid by itself. The selection and interpretation of COVID testing, and it's adapting to how the pandemic that we lived with for the last 20 months has been evolving. To start with, I think I need to share a disclaimer with you. I am not exactly a clinical chemist with deep knowledge and everyday practice of clinical lab testing. So why did I accept to do this talk? Honestly, because I believe I can provide a fairly meaningful perspective from someone who is responsible for a large urban lab in a large Midwest city that has been hit very significantly with the pandemic in the spring of last year. Our university, Wayne State University, is located in the heart of Detroit, and the associated institutions are the Detroit Medical Center, a 7-hospital site system, and a comprehensive cancer center of Karmanos. So our laboratory in pathology serves all of these entities, meaning a university practice, the cancer center, the Detroit Medical Center, including a standalone children's hospital. So there was a very unique perspective on taking the test not in isolation, but really how does it reflect on the practice and patient care in many of these segments. Also, when I was putting these slides together, they made me reflect on the concept of testing and imaging, which in imaging and labs, that's where most testing take place. But in general, when you look at the tests per se, what is it that we are looking for? A very wide spectrum of things, really. The identification of an agent, if we are dealing with infectious disease, substance or abnormality, if we are dealing with a whole host of degenerative metabolic diseases, etc. And what we are looking for, and this is not a whole encompassing list, can vary from the mere presence of an abnormal substance to the quantitation and where does that value that we quantitated fit in within the normal ranges. Also within the testings are assessment of vital functions and organs, respiratory function tests, renal tests, kidney functions tests, etc. The significance of what we find, because in many of these tests, sometimes there are gray areas, maybe a little bit below or above what have been established as normal ranges. And the judgment about what to do with it is sometimes subjective, honestly. That's not to speak about the different instrumentations and companies that have equipment with ranges that may be a little bit different from each other. So comparison becomes also an issue. The implication for management, of course, is the most important thing. So if we move to infectious disease and testing, that's really the topic of today. You need to identify a pathogen. What is the cause for a certain disease or compilation of symptoms of a disease? Often, the symptoms and the manifestation of what looks like an infectious disease often becomes known prior to identifying the agent causing them. An anecdote, when I started my pathology residency in the early 80s at NYU in New York City, a mysterious compilation of serious conditions started to manifest at the time within certain demographics, younger and middle-aged men. And we started in the lab, in pathology, to see samples with evidence of immunocompromised status. Rare infections like pneumocystis carinii pneumonia, atypical tuberculosis, mycobacterium, and under the microscope, when we were starting to learn about the traditional Kaposi sarcoma, Mediterranean in middle-aged men, we started seeing it in the oral mucosa, in the respiratory passages. So this compilation of symptoms, it didn't take too long to figure out that there is a pattern of transmission, and people quickly started to think there is an agent that's causing these symptoms, not identical in everyone, but certainly in a transmission fashion. It took at least a year and a half, till the Pasteur Institute in Paris and the NIH isolated and identified the human immunodeficiency virus at the time. Took some additional time to develop a valid test for HIV, and then the HIV AIDS complete spectrum of the picture. And until this day, we do not have a vaccine for HIV, and the testing within the labs, I know we handle it till today with certain confidentiality and counseling between the clinicians and their patients for their individual care and issue, but also the implications for their current and maybe past relationships. So in infectious disease, when we talk testing, it's really a complex spectrum. We need to develop and validate a testing methodology. And then when we are dealing with a pandemic, such as what's happening now, there is a need to build testing capacity, which we utterly failed as a country, a health system, in meeting, at least for many months during the beginning of the pandemic. So when you look at testing in general, beyond infectious disease, you need to attend to the patient themselves and take care of their ailments. Beyond that, in infectious disease, you need to look at the implications for people surrounding them. And beyond infectious disease, many of the tests are used to set guidelines for care. We're talking a spectrum of laboratory testing, of imaging testing, from mammography to PSA testing to set certain guidelines for screening for breast and prostate cancer. There is a growing science right now, and a very promising one actually, using laboratory medicine to assess the health status in certain geographies. When you think about hospitalized patients whose testing tend to be more comprehensive, not only targeted in the case of an outpatient setting, there is a wealth of data that is available to the hospital and the laboratory, the specialties, totally within HIPAA guidelines, totally protected information, totally anonymous. But when you look at it collectively, let's say in a zip code, and you take a look at renal functions, at lipid profile, at indicators of pre or established metabolic syndrome, there is tremendous amount of information and potential for management that one can ascertain. Coming specifically to COVID and the stages of testing that evolved. As many of you know, the infectious agent was known, this is infection, and we need to see how we can test for it. One of the first attempts was that of the CDC, and unfortunately, it did not go very well, and we don't have time to go into the reasons for that. The industry stepped in and offered several platforms to test for COVID. And they benefited also from the fact that this version of the virus, while it's new and its transmission is particular, it did share some commonalities with previous versions that we knew 10 and 12, 15 years ago. So a PCR test to identify the genomic material of the virus was developed. And to share with you the really difficult road that evolved from, I would say, February, March to way into the summer of last year. I noticed that Phil Levy is among the guests and the speaker here, and him and I and many others partnered in securing the ingredients for the testing. Phil is an emergency medicine doctor who's really a clinical scientist and a population health individual. So we worked together in the lab and Wayne State University to buy equipments. There were very few equipments available to provide the platform for the testing. And when we secured that, the next step was to make sure that there are enough clinical providers who are trained well to obtain samples. This is not exactly your everyday phlebotomy, swabbing the upper respiratory mucosa in an adequate fashion that yields enough samples to avoid false negativity is something that needs to be learned. And then these samples go to lab. You need to have lab personnel trained on a new testing platform. That platform, when it generates results, it needs to be validated. So we're talking literally weeks for many of these steps, although we tried as a system to make many of them go parallel rather than sequential. The biggest bottleneck in this process was supplies of test kits for COVID-19. And I have to say, and I think I'm not by any stretch alone in this, that for a tremendous resources and science and intellect, there was really very slow building up of these samples to cover the need. The need was tremendous, and we found ourselves, I rarely talk to lab reps, but I found myself on the phone very often, asking about allocations, sometimes begging to increase our allocations, and then from there, you go into prioritizing where these precious tests should go first. Kids before surgeries, immunocompromised patients. I talked about the cancer center with bone marrow transplant, one of the biggest 10 in the nation, very large numbers there. So there have been tremendous interactions with many entities when you talk about testing. As I indicated, I'm not really talking about the technical laboratory aspects of the test. Antigen testing came on the scene, and it's still there, but really not a very popular way of identifying the virus currently, at least in confirming the infection. Most laboratories and clinicians are very reliable on the PCR testing. And then antibody testing came, and not in the context of diagnosing the virus, rather to look at the after the infection and maybe after the vaccine status also. So some of the very frequently asked questions, and they can be a given for most of our colleagues. Can PCR testing detect COVID-19 variants per se? As you know, variants are proliferating. There is a talk in the last 48 hours or so about some new variants, and also very infectious in addition to Delta. So the ability of PCR tests to identify the variants is really not much in question. Yes, most PCR tests in every platform can determine the positivity by detecting the viral genome. Now, can PCR tests determine which variant have infected this particular patient? The answer is no. This requires sequencing. When you sequence the genome for a viral infection, it's really a very tedious process, takes long time. Any lab that attempts to do it needs a very long validation process. So typically in most states, at least in the state of Michigan now, these are done at the state lab. So what happens every day? Every lab that performs COVID testing in the state of Michigan have to submit an average of 10 samples a week. And that translates to many hundreds of samples, considering the multiple health systems that are there and many private outlet labs. And out of that fraction, the state can sequence a fraction also. However, they do get a good impression about what's causing the infection at this given time, typically in windows of weeks and months. Currently, in Michigan and probably in the other 49 states, 95%, to the best of my understanding from what I'm reading, are caused by the Delta variant. And by the way, state labs do not report back individual results to labs or certainly patients. Now, for serological testing, for the antibodies against component of the COVID-19. As I said, this does not replace the virological testing as a first step diagnostic. In terms of the performance of these antibody testings, there is some variations in their performance and the characteristics needed for ranges of values, and especially the semi-quantitative values that have been given an emergency authorization use, and it still enter that status. There is currently no recognized clinical indication to use quantitative tests. Other word, and I'll come back to this a bit later, that certain level of antibody translates to certain level of immunity or durability of the immunity. When you look at the very simplified schema of the COVID-19 structure, a few components are worth pointing. The spike S protein, S1 and S2, these are antigens that are easily made, or antibodies are easily made for. So the matrix and the envelope are important. And the next one really is the nucleocapsid, the genomic material of the virus. So when we look at these components, the antigenicity of the virus, there are more than one thing, and I will go into the epitopes also in a minute. So there are at least 4, maybe 5 components as antigens that potentially the body would develop antibodies for. Antibodies to the spike protein are the results typically of both vaccine or infection. When you look at the antibodies for the nucleocapsid or the envelope or the membrane, these spikes can be the result of infection. The reason for that is the vaccines, almost every vaccine in the USA and probably worldwide, there are many variations on the manufacturing of vaccines. And as you know, some are more public and known than others. But let's take the US. All the vaccines target the spike protein. So if you have antibodies for the envelope or for the nucleocapsid, in all likelihood, you have been infected with the virus actually, rather than been vaccinated only. And that's actually a differential. And as you know, emerging data right now for the big breakthrough infection indicates that patients who were infected and they came back to full recovery may be more immune to the second infection than those who have been vaccinated. And probably this slide explains it at least partially, because the spectrum of antibodies that they have is wide and comprehensive, as opposed to the antibodies provoked by the vaccine, which are only against the spike protein. So the COVID targets for the antibody assay used currently in the States, 50 of them, and these come to about 150 in total. 50, full 1/3, uses the spike protein. Under 10, 9 use the nucleocapsid. A combination of both is just under 20. And then there are those that measure the immunoglobulin, IgG and IgM, or the total immunoglobulin response. So to give you an idea about the complexity of the task here, while out of fairness and balance, when one talks about the failure of the huge pharmaceutical industry to respond with adequate supplies for the test kits, I think the laboratory science and beyond, certainly beyond the laboratories, the genomics, the infectious disease, the multidisciplinary medicine at large, was able to develop vaccines based on what we learned of the virus in a definitely record time. So here's part of the complexity. When you look at the human serum albumin, you look at only 16 reactive epitopes that you need to develop antibodies for. Something like the HBs antigen, 140, under 150 reactive epitopes. For SARS-CoV-19, we're talking about over 800 reactive epitopes. So the level of complexity is really very, very impressive here. The interim recommendation for use of serologic testing. For acute infection, we still go by the nucleic acid amplification test. For resolving or previous infection, it's best determined by serological testing that detects antibodies. To try to assess the level of immunity, how durable was the immunity after either the infection or the vaccine, this is really still far from an exact science. Much of it has to do with the variations of the measurements, the individual status. So to translate a number, a level of antibody to a level of immunity, to the best of my knowledge, this is not clinically utilized at this point. As you know, there is an acknowledgement, however, that the immunity built by the vaccine, at least, would start to wane down by month 8, maybe even 6. And a third booster is not only on the horizon. I know in some places, including the Detroit area, some people have received that already. So, interpretation of the results. Persons suspected to have COVID-19 are typically developing antibodies within 1 to 2 weeks. If you look at the general picture of the infection itself, peaking by 1 to 2 weeks in terms of the viral load and the symptoms, and then waning down, hopefully resolving if it is going to resolve within 4 weeks. The first antibody to come on site is IgM, starting at the end of week 1, but typically declining before a month, 3 weeks. IgG continues to rise, and when it peaks at around day 25 or so, but its decline is much more gradual than the rest of the antibodies. So for the interpretation of the results, we talked about this in both the person who had not been vaccinated or infected, and in terms of those who have been vaccinated. Very quick word for antibodies. They talk about plasma and convalescent plasma is took place for a while. That's treating patients with antibody-rich plasmas. It really did go by the wayside in the last few months because the antibodies proved to be much more powerful as a treatment. I'm not going to spend much time on the details, but in a sense, the plasma did not prove to be harmful by any chance, but its beneficial effect was not really proven. So before we had the antibody, plasmas were really the way to go, convalescent plasma. Now with the antibodies, there have been known ones that have been developed and authorized, at least for emergency use. And to show you a very quick study looking at equal numbers of those who received and did not receive the antibody cocktail, hospitalization and death was 70% in those who did not receive it, compared to 2 with those who received the antibody. And by the way, the 10 deaths were only in the placebo arm, patients who did not receive the monoclonal antibody. There are also antibodies against CD6 for the cytokine storm, known to be a manifestation of COVID-19, and anti-interleukin 6 receptor also, which block COVID-19 related inflammation. As you know, this could be also a very harmful effect. In the US currently, as I alluded to, you cannot know what variant of the virus you are infected with. Actually, it's legally not possible, and I discussed the issue of sequencing and the need for validation. That's the major reason, in addition to the cost and the difficulty testing everyone by sequencing. Finally, the pandemic appears to be continuing, fluctuating. Everyone is very leery of what this fall may bring. We are experiencing some rise here, not anything similar to what happened in the South, in some of the states in the southern part of the country. One of the major reasons for concern is the majority, more than 75% of individuals who are infected by Delta, they do not become symptomatic till a full 48 hours after the infection. So when you look at the purpose, on the final slide, of COVID-19 testing today is to determine the presence of the virus genome, PCR is definitely the way to go, and the sample for that is mucosa of the upper respiratory tract. For the antibody testing, we discussed that in some details, and the sample for that is serum. One quick word about self-administered testing. It's very common right now, and in a sense, some variations of PCR methodology. However, the false negative here is much higher than that of PCR performed in labs. Perhaps the reason for that is the inadequate sampling. At least one of the reasons. When you're sampling yourself, probably you're more cautious in not hurting oneself and maybe not obtaining adequate samples. So I think that's my last slide, and I appreciate your attention. I know we utilized the half an hour, so if there are any questions, please email them to me, and I'll be happy to try to answer them myself and my laboratory team. Thank you.